Hello students, and welcome to Pharm.D Guru. In today's session, we'll be discussing an essential topic, pharmacokinetics of drug interaction. Let's go to the topic, shall we? This is the syllabus we are going to cover in this session. The material I am using in this video is available in our website www.pharmdguru.com. So let's open our study material. Now let's discuss about our first topic, which is pharmacokinetic drug interactions. Before going to the main topic, let's learn about what drug interactions are. This whole section is about the introduction to drug interactions, and I will explain here about the highlighted section. Drug interaction is when a medicine reacts with another drug or even with food in a way that changes how the medicine works, sometimes making it stronger, weaker, or causing unexpected side effects. Imagine you take one medicine for fever and then take another medicine for cold. These substances can mix inside your body and change how the fever medicine works. It might work too strongly, too weakly, or cause a weird side effect. This reaction between two substances is what we call a drug interaction. In most cases, drug interactions are bad, and doctors want to avoid them. But sometimes, they can be helpful if used smartly. For example, some medicines can be made to work better when another drug helps keep them longer in the body. Let me give you a real-life example. Let's say a patient is taking penicillin and antibiotic. If they also take probenecid, which is a drug used to treat gout, it can actually help penicillin stay in the body longer, making it more effective. So, this is a rare case of a beneficial drug interaction. In drug interactions, there are two roles. The object drug, the one that gets affected. The precipitant, the one that causes the change. In our example, penicillin is the object drug and probenecid is the precipitant. There are two main types of drug interactions, pharmacokinetic and pharmacodynamic. Let's break that down. First one, pharmacokinetic drug interactions. These interactions change the amount or duration of a drug in your body. Think of it like this. You take a pill, and it travels through your body, absorbed, distributed, broken down, and finally removed. Okay, no problem. But if another drug comes in and changes any part of the pill's journey, it changes how much of the drug is in your body and for how long. This is called a pharmacokinetic drug interaction. Example, imagine there is a drug B, which usually undergoes ADME and leaves the body in, let's say 3 hours. And you also took drug A. If drug A slows down the liver's ability to break down drug B, then drug B stays in your system longer, let's say 5 hours. That might cause too much effect or side effects. Now let's see the second one, pharmacodynamic drug interactions. These interactions happen when drugs change each other's effect, either boosting or cancelling each other out. This one is about how the drugs act, not how much is in the body. So even if drug levels are normal, two drugs can interact at the site of action, either helping each other or working against each other. Let's see example 1, additive effect. If a patient takes two medicines that both lower blood pressure, the combined effect may cause the pressure to drop too much. That's an additive effect. The total action is stronger than expected. Example 2, opposing effect, cancelled out. Let's say one drug raises blood sugar and another lowers it. If you take them together, they might cancel each other out. That's a pharmacodynamic interaction with opposing effects. Here is a simple analogy of opposing effect. It's like pressing the accelerator and the brake at the same time in a car. One drug says, go. The other says, stop. The car doesn't know what to do. So, in summary, pharmacokinetic interactions are about how much drug is in the body. Pharmacodynamic interactions are about how drugs act, together or against each other. So, let's go to our main topic, pharmacokinetic drug interactions. Let's talk about pharmacokinetic drug interactions. These are the interactions that change how much of a drug ends up in your system and for how long. Pharmacokinetics means what the body does to the drug, from the moment you swallow it to when it gets absorbed, moved around, broken down, and removed. Now, if you take two drugs together and one of them changes the way your body handles the other, that's called a pharmacokinetic interaction. These are also called ADME interactions because they affect absorption, distribution, metabolism, excretion. Pharmacokinetic drug interactions are classified into four types. They are absorption interactions, distribution interactions, metabolism interactions, excretion interactions. Now, let's look at these interactions one by one. Let's now explore the first major type of pharmacokinetic drug interaction, absorption interactions. This type of interaction happens when one drug changes how well or how fast another drug is absorbed into your body. Since most medicines are taken by mouth, these interactions usually happen in the stomach or intestines. We can say the digestive tract. The result? The drug might get absorbed too quickly, too slowly, or not enough drug might get absorbed at all. Absorption interactions happen mainly in three different ways. Changes in gastrointestinal pH. Some drugs need an acidic environment in the stomach to get absorbed properly. If another drug changes the stomach's pH, absorption can be affected. Simple example, take the antifungal drug ketoconazole. It only dissolves in acidic conditions. But if you also take a proton pump inhibitor like pantoprazole or antacids like gelusil, aluminum, magnesium, they reduce stomach acidity. That means ketoconazole won't dissolve well and you'll absorb less of it. Here is a simple analogy. Think of it like trying to dissolve sugar in cold water versus hot water. The hotter the water, the faster and better the sugar dissolves. If the water or your stomach isn't acidic enough, the drug doesn't dissolve or absorb properly. Changes induced by chelation. Some drugs can form chemical bonds with minerals in the stomach, creating insoluble complexes that your body can't absorb. Simple example. If you take tetracycline or ciprofloxacin along with milk, which contains calcium or iron supplements, they can bind together, forming a complex your body can't absorb. This reduces the antibiotics effect. Doctors often say, don't take these medicines with dairy or antacids. And if you must take both, keep a 2 to 3 hour gap between them to avoid the interaction. Changes in gastrointestinal motility. Some drugs affect how quickly your stomach empties. That can either speed up or slow down the absorption of other drugs. Example 1. Propanthyline, a drug with anticholinergic properties, slows gut movement. If you take it with digoxin, slow dissolving, it stays longer in the stomach, giving it more time to dissolve and be absorbed. This increases digoxin's absorption by 30%. Example 2. Metoclopramide, on the other hand, speeds up stomach emptying. So, it reduces the time available for the drug to dissolve and thus lowers absorption of digoxin. Now let's talk about the second type of pharmacokinetic drug interaction, distribution interactions. After a drug enters your bloodstream, it doesn't just float around randomly. It travels. And how it spreads through your body is called distribution. Now, most drugs in your blood don't float freely, they stick to proteins in your plasma. This is called protein binding. But only the free, unbound part of the drug can actually work or be active. Think of it like this. Here is a simple analogy. If a drug is tied up or stuck to a protein, it's like a worker on break, not doing its job. Only the free workers can get to work. But what happens if two drugs are given together and they both want to stick to the same protein? They start competing for space and one of them gets kicked off the protein. Now, that displaced drug is suddenly free in the bloodstream, which can increase its activity and sometimes cause toxicity. Example, take the blood thinner warfarin. It's mostly bound to plasma proteins, about 99% of it. Now, if we give phenylbutazone, a strong anti-inflammatory drug, along with warfarin, it displaces warfarin from the protein. That means more free warfarin in the blood, which can cause excessive bleeding because its effect suddenly increases. Real-life analogy. Imagine you have a hotel with limited rooms and two VIP guests arrive. One kicks the other out of the room. Now that person is roaming free, and he might cause chaos, toxicity. Not all drugs cause such interactions, though, but some have a higher risk. Here are the risk factors for distribution interactions. Drugs that are 90% or more protein-bound. Drugs that have a low therapeutic index, meaning small changes in dose can cause big effects. Drugs that are given IV or stay mostly in the blood. Drugs that are tightly bound to tissues. Common offenders, drugs that often displace others include NSAIDs like ibuprofen, diclofenac, phenylbutazone, sulfonamides, salicylic acid in aspirin. So, in summary, distribution interactions happen when drugs fight for the same protein spot in your blood. The loser becomes free and active, which can boost its effect dangerously. That's why understanding protein binding is important in drug therapy. Next, let's explore another major type of pharmacokinetic drug interaction, metabolism interactions. Once a drug enters your body and gets absorbed into your blood, it usually travels to the liver where it gets broken down or metabolized, so your body can use it or remove it. Now imagine your liver has tiny machines called enzymes that cut the drug into smaller pieces. But here's the twist: some drugs can either speed up or slow down these machines. That's when metabolism interactions happen. Metabolic interactions are divided into two parts. Part 1. Stimulation of metabolism, enzyme induction. Part 2. Inhibition of metabolism, enzyme inhibition. Part 1. Stimulation of metabolism, enzyme induction. Some drugs increase the number or activity of liver enzymes. This is called enzyme induction. Think of the liver enzymes like workers on a drug-cutting assembly line. When a drug like phenobarbital is given, it calls in more workers, speeding up the breakdown of other drugs like warfarin. Real-life analogy. Imagine you have 5 workers cutting vegetables. Suddenly, 10 more workers join. Now veggies are chopped super fast. But that also means if the vegetable drug was supposed to cook slowly, the job's over too quickly, and it doesn't last. Example: phenobarbital induces liver enzymes. So when it's taken with warfarin, a blood thinner, warfarin gets broken down faster. That means its blood-thinning effect weakens, and the risk of clot formation increases. In summary, enzyme inducers make the liver break down drugs faster, reducing the drug's effect. Part 2. Inhibition of metabolism, enzyme inhibition. On the other hand, some drugs block the liver enzymes. This is called enzyme inhibition. Now imagine the opposite. What if the liver workers go on strike? No one is there to break down the drug, so it stays longer and may become too strong or toxic. Example: let's look at alcohol and disulfiram. Normally, alcohol is broken down in your body by an enzyme called alcohol dehydrogenase, then further processed into acetaldehyde and finally into a harmless form. But disulfiram blocks this process. It inhibits the enzyme. So what happens? Acetaldehyde builds up in your body, causing headache, nausea, flushing, vomiting, a very unpleasant reaction. Real-life message. That's why disulfiram is used to treat alcoholism, because it makes drinking a horrible experience. In summary, in metabolism interactions, one drug can either speed up or slow down how your liver processes another drug. If metabolism speeds up, the drug effect weakens. If metabolism slows down, the drug effect becomes stronger and possibly toxic. Now let's talk about the fourth type of pharmacokinetic interaction, elimination interactions. After a drug has done its job in your body, it needs to be removed. Most of the time, this happens through your kidneys, urine, or liver, bile. But sometimes, other drugs block or slow down those exit gates, or even change the rules of exit, leading to problems. Elimination interactions happen when one drug affects how another drug is removed from the body. Major exit routes: urine and bile. Most drug interactions during elimination happen through the kidneys, where the drug leaves in urine. Bile elimination, through feces, is less commonly involved in drug interactions. It's more affected by diseases, not other drugs. Mechanisms of excretion interactions. There are 4 main ways drugs can interfere with each other's elimination. 1. Alteration in renal blood flow. Kidneys filter drugs from the blood. But what if less blood reaches the kidneys? Example: NSAIDs, like painkillers, can reduce kidney blood flow. So, when taken with lithium, a psychiatric drug, lithium doesn't get cleared properly. It stays in the body longer and can become toxic. Real-life analogy. Imagine a water purifier. If less water flows into it, less water gets purified. Similarly, if less blood flows to kidneys, less drug is filtered out. 2. Alteration in urine pH. Some drugs are excreted better in acidic or basic urine. Changing urine's pH can speed up or slow down elimination. Example: antacids make the urine more alkaline, basic. If taken with amphetamine, which is eliminated better in acidic urine, it slows down its excretion, keeping it in the body longer. Here is a simple analogy. Think of a detergent that only works in hot water. If you switch to cold water, cleaning becomes inefficient, same with urine pH and drug removal. 3. Competition for active secretion. In the kidneys, some drugs need to actively compete for a spot on a transport belt to be removed. If 2 drugs fight for the same seat, one gets left behind. Example: probenecid and penicillin both use the same transporter. Probenecid blocks penicillin's exit, so penicillin stays longer in the body, which can actually be beneficial in some treatments. Real-life example. Think of 2 people trying to get into a taxi. If one blocks the other, the second person can't leave and stays longer. 4. Forced diuresis. Sometimes, we force the body to pee more to get rid of certain drugs quickly, like in cases of drug overdose. Other drugs can help or interfere with this process. In summary, elimination interactions can slow down or speed up how quickly a drug is removed from the body, especially through the kidneys. This can change how long a drug works and whether it becomes too weak or dangerously strong. That concludes the first part of our chapter. The remaining topics: B. Inhibition and induction of drug metabolism, and C. Inhibition of biliary excretion, will be continued in the next video, which is part 2.